So you'll agree Pakistan has greatly improved in diabetes management over the years.
It's a very pertinent question. At the outset, a slight note of disagreement.
So diabetics can't eat sugar, but they can eat as much fruit as they want.
I think you've heard the statement before, too much of anything is wrong.
Mostly people think that overeating causes diabetes and somebody who's lean will never be a diabetic.
Not true particularly.
If you were in the leading position over there in that ministry, what would you do differently for Pakistani population?
It's a very pertinent question once again.
Assalamu alaikum. Martin Dr is here yet again with our newest initiative, Meethi Baatein, which is a digital show highlighting diabetes and Pakistan. My name is Saqib and I'm part of Martin Dr cardiometabolic marketing team. With us today we have Dr. Ali Arif, consultant medical specialist, diabetologist and assistant professor, PIMS Hospital, Islamabad. कैसे हैं सर आप?
So very much Saqib, alhamdulillah, all well?
Right, sir. To start the show, I would request you to share with us a background of your patients, their socioeconomic class, and how they usually represent to you.
Saqib, the actual aspect is that the socioeconomic class of patients with diabetes in Pakistan is pretty extensive. You'll find patients who are laborers by profession, housewives, stay-at-home dads, industrialists, tycoons. So you'll find that despite thoughts to the contrary, diabetes is a very broad spectrum disorder and goes beyond social class and social status.
So you'll agree Pakistan has greatly improved in diabetes management over the years. But still, diabetes being a multifactorial disease, there are some parameters that are still not being addressed, such as physical activity in Pakistan. Apart from the therapeutic management which you usually do in your clinical practice, what are some of the biggest lifestyle changes you wish your patients would do or make in their lives?
It's a very pertinent question. At the outset, a slight note of disagreement. I won't necessarily say that the diabetes management strategy has greatly improved over the last few years. We have a huge armamentarium of drugs available now. We're able to manage things. We're able to pick up things earlier. Yes, awareness has definitely increased, courtesy in part to what you're doing here today. But the actual aspect which remains unsettled, especially in the Pakistani population, is diet, exercise and weight loss.
Right, sir.
We have major hurdles beyond medical therapy, and lifestyle interventions a major one of them. Most of our patients, in my opinion, remain in a caloric excess. Despite financial constraints, the vast majority of our diabetic patients are obese. They're not very physically active. Their portion control is non-existent. So we're dealing with a lot of things just beyond blood glucose.
So, sir, leading on with your answer, what do you think is the reason? Is the reason the inability of understanding the concept of healthy eating in Pakistan?
That's one major part to it. What we fail to realize, I believe, as a nation, is that with the course of time, our basal metabolic rate tends to decline. We continue to eat the way we would in our teens, in our 20s, and those rules don't remain applicable when you cross over into your 40s or 50s, for example. Number two, we have certain body concepts in the country, whereas we think that a thin, lean individual is unwell, and we believe that somebody who's overweight and obese is actually healthy. I've had these discussions with patients, and they do tend to mention that ABC's son or daughter is so weak, please give them something so that they can gain weight. And it's a difficult message to hammer home that that person isn't overweight, they're not obese, they're on an ideal body weight. Yes. And the concept of what we believe is healthy as Pakistanis is actually those individuals who are overweight. So it's a bit of a struggle. Right. Changing stereotypes, focusing on those things, but there are multiple issues that we do need to address.
Sir, if we talk about Pakistan, like every other country, there is an NCD unit within the Ministry of Health. However, it does not have a strategy to address or reduce the physical inactivity in the general population right now. If you were in the leading position over there in that ministry, what would you do differently for Pakistani population?
It's a very pertinent question once again. Sadly, like so many departments that are part of various ministries, various organizations, they're not particularly functional. They exist there on paper, but you don't see any activities being carried out. You don't see awareness being created to that degree. You don't see a proactive approach per se. But what needs to be done, and I think that would apply all over, not just for Pakistan, is to start early. The major driving force behind type 2 diabetes is insulin resistance. And the major driving force behind insulin resistance in the vast majority of cases is either obesity or being overweight. Right. And this tends to start very early. If you've noticed, you're a parent yourself, childhood obesity.
It's a menace, yes.
Whenever I go to drop my daughters off to school, one thing that I do notice is that most children going to school are overweight. And that's an area where we need to focus on. We need to regulate activity, encourage healthy behavior, avoid a lot of food substances that are easily available, especially in school canteens and cafeterias. I mean, I can't just criticize children. Adults are in the same category as well. We can't enjoy a meal without a carbonated beverage.
Yes, we can.
And we do need to fix those habits as well. And I think the Department for Non-Communicable Diseases needs to focus on that as well. Prevention, prevention, and prevention. And once you have developed obesity or overweight patients, then we need to work on trying to reduce that as well. Highlighting the fact that a lot of things are preventable if you start early. And that's what we need to do.
Further on, sir, just as you have mentioned about childhood obesity right now. So that starts from your home, right? We can't, as you said, blame the government for everything. How do you see the role of family as enablers in maintaining a healthy lifestyle? May it be physical inactivity or may it be a healthy food choice at your home. How do you see that works, and what do you recommend the family members to do, especially in the different roles that they have? For example, if your father is obese, how do you go and tell your father that, you need to make changes? Yes. Or how do you ask your mother that, even if you're doing household chores, even if you're doing housework, still that is not, sufficient enough for you. You need to get out, you need to increase your mobility. So how do you think we can address this or handle this?
You're throwing a lot of pertinent questions my way today. I think your question has 3 or 4 prongs, so I'll take them one at a time. Absolutely. I think the fact that we're overweight, we're obese, we've got a very, very high prevalence of diabetes. A lot of factors are social in nature. When it comes to entertainment, our most entertainment avenue is eating.
Yes.
Eating on festivals, eating on occasions, sadly eating on sad events as well. Everything focuses purely around the meal.
Yes.
All right. Sadly, a lot of those foodstuffs are far from healthy. We don't consume raw fruits, raw vegetables. All of our foodstuffs generally are fried. They're not just, when we don't use limited amounts of oil, we essentially deep fry everything that we have. We have very high carbohydrate diets. And once again, I think it comes back to education. Understanding that we don't need to throw anything off the menu, but we do need to improve those choices. We need to try to incorporate more vegetables, preferably raw.
Vegetables without frying them.
Absolutely. I mean, something that I tell my patients as well is that if you're feeling hungry at an odd time of the day, please have a carrot.
Yes.
Have some cucumber. Take some lettuce. I mean, these are healthy snacks that can induce satiety, reduce the chances of you overeating at the same time, and lead to a healthy body weight. Now, the second part of your question was, how do we deal with family members, especially those who are older than us, entitled to our respect when they're overweight or obese? And I think the aspect, once again, comes down to the fact that we need to aim to prevent illness. We tell our parents, we tell our loved ones that in the long run, I mean, I don't mind what you're eating. I mean, I'm very happy to see you happy. But if it's coming at the cost of your health, then it's not a good choice to make. being overweight, being obese is going to cause a lot of problems other than diabetes. Osteoarthritis, for example. I sometimes joke with my patients in a slightly humorous way. I tell them that as far as the knees are concerned, and this is with all intended respect, that you've technically put the tires of a Mehran under a Prado.
Yes, yes.
So what's going to eventually happen is those tires are going to give way. And we do need to focus on reducing morbidity as well. And weight loss is a major, major role that we can use for that purpose. And when another thing that we can do is, once again, I tell my patients' caregivers this as well, that it would be unfair for us to stop other members of the household from doing something if we're indulging in the same behavior. So if my parents or my siblings or my grandparents aren't going to have soft drinks, neither am I. It goes across the board.
Definitely.
If I'm going to ask them to take salads, then I will partake in that exercise myself as well. So I think if it becomes a social change, that everyone in a certain household starts doing something, then change becomes easier, becomes less of an imposition. We won't be forcing something just on patients with diabetes or patients who are obese or individuals who are just at risk. We'll be making a change that will occur over the board, across the board essentially, everyone at home adopting healthier behavior.
And only then will it work.
Absolutely.
But sir, owing to our culture, the Pak Indo culture specifically, would you be comfortable telling your wife, I know you would, but about the general people, that you need to lose weight, you're obese, you need to do something, or vice versa?
I think it comes down to how you're saying it to somebody. I mean, if you tell somebody that you really care about them and you don't want to see them falling ill, and there are so many things that could happen. You lose longevity in life, you lose quality years.
Definitely.
So if you tell your spouse in question that, look, for the last so many years, I think we've both been putting on some weight. And quite frankly, it's not about the external appearance. It's about the possibility and probability of developing chronic illnesses that just don't go away. So if we invest in our health together, maybe we could live a longer, happy life together as well. It depends on depends essentially on how you say it.
How you say it.
You tell the other person, look, you're fat, you need to lose weight.
That's gone.
I don't think that came off too well.
Yes, definitely.
But you tell them that, look, I value every minute that I've got with you, and I don't want to lose out on it.
Yeah.
And weight itself can be such a harbinger of illnesses that if we invest in trimming the weight right now, maybe we can live a happier and healthier life.
We can definitely, sir. You're very right about this. Further, sir, let's discuss a few more enablers. Family is one of the enablers of physical inactivity in Pakistan. But there's another enabler, and that is the local guidelines we have in our country, right? So right now, the local guidelines are recommending a one-size-fit-all approach. And they're recommending the same things to males and females in Pakistan. But do you think, sir, in a country such as Pakistan, where gender plays a very big societal role, and where there are not enough public spaces, do you think that all those recommendations are applicable specifically to the women who think working at home is the only physical activity they require in their life?
Once again, a very pertinent question. The simple answer would be no. One size can't fit all. It shouldn't either. There are gender differences, societal differences, accessibility to places, facilities, luxuries in that, for that matter.
Yes.
And I feel that we need to try to help patients as patients, regardless of their gender, but focusing on specific needs as well. Now, I'm not going to be racist in any way, but we have a lot of cultural limitations. I mean, quite a few patients do end up mentioning that the females in their household aren't allowed to step outdoors, which in my opinion is very wrong, and that needs to change.
Or they require a male escort, somebody who's escorting them with,
But even then, more often than not, they're not allowed to. And that's a societal change that we need to bring. But sadly, Saqib, you and I can't bring that alone. It's a mindset change. It will take time through education. But in that time, In the meanwhile, what we do need to make people understand is that any sort of physical exercise is welcome. Sadly, household chores are quite often not enough. They do need to be supplemented. There are lots of exercises that can be done within the boundaries of the four walls of your house as well, whether it's resistance training, whether it's stretching, whether it's yoga, whether it's Pilates. There's so much that one can do.
Yes.
But we need to encourage them to do it. At the same time, I do recommend that where possible, whenever possible, step out of the house. I feel that exercise is the most underutilized medication, especially with regards to diabetes and obesity. The same applies for men as well. You'll find, once again, understandably, people are tired, people are frustrated, they're exhausted, they don't manage to take time out. But what I do tend to tell them is we do manage to take time out for what matters.
Yes. Exactly. And this matters. And this matters.
This is something that should matter.
Yes.
And we need to reinforce that concept that please do take some time out. It doesn't necessarily need to be 2 hours a day at the outset. For people who aren't doing anything at all, start with 15 to 20 minutes, maybe twice a day. Break it down into short bursts. If you're doing something at home, 10 minutes 4 times or 5 times a day will get you at the same level that maybe our Western counterparts are on as well. So, answering the question, one size can't fit all. We do need to tailor make our recommendations to our patients in particular, because if I tell somebody who hails maybe from a tribal setup to go join a gym,
they won't. They won't. Yeah, that's not going to happen.
It's not fair for me to make that suggestion. Likewise, I can't say go out jogging every morning because their societal restrictions are going to come in there. And I can try to encourage, for example, male members of the family that look, the lady in question is fully entitled to the same physical activity that you are. It's her right, and you shouldn't be denying it to her. Once again, religiously, there is no denial of this right. Society has made things a bit different.
Yeah.
But, notwithstanding, if there's still difficulty, then what you can do is try to do something at home. And we need to encourage people doing that at home as well. Give each family member individualized time.
Yes.
Maybe away from the mundane chores of the household, away from looking after the children. Some, maybe even half an hour, 45 minutes in a day of total me time. Dedicated to one's health, dedicated to oneself, to enable them to achieve a healthy lifestyle.
So what you're saying, sir, to sum it up, household chores are not enough for women.
Sadly, no. And quite frankly speaking, not enough for men either.
Not enough for men either.
Frankly, once again, I believe the gender stereotype needs to be broken. Household chores aren't necessarily a female responsibility.
Yes,
the household is something that's shared by both. They should be shared.
Religion, yes. So moving on, sir, now I'd like to address some of the myths that have been associated with diabetes. And as you know, sir, myths are tales or fables which have been passed on from generation to generation. So I'm going to throw some very fast questions at you, rapid fire, and you'll tell me yes or no or a concise answer to it.
Sure.
So mostly people think that overeating causes diabetes, and somebody who's lean will never be a diabetic.
Not true particularly.
Not true.
However, there's a very strong association between obesity, insulin resistance, and type 2 diabetes. That does not mean that thin, lean individuals are free from diabetes. There's a concept, toffee.
Yes.
Thin from the outside, fat on the inside.
Yes.
People may have a fatty liver. They may have raised cholesterol, they may have the metabolic syndrome, whilst being at a normal body weight as well. So yes, although the chances of developing diabetes do go down, if you maintain a healthy lifestyle, are thin and lean, that does not rule out the development of diabetes.
So even a lean person has to get tested.
They should ideally be followed up at regular intervals, and testing is the best way forward, I suppose.
And what are the regular intervals you will suggest?
What I tend to recommend is an individual who has a strong family history. Other risk factors as well, heart disease, cholesterol-related problems, they should get tested every 6 months or so.
Right, sir. So from what you just said, if somebody has a family history, my father has diabetes, Do you think diabetes is contagious? If my parents have it, I'll catch it, sir?
Once again, a common myth. No, as you mentioned earlier, it's a non-communicable disease.
Yes.
It can't be transferred from one person to the other via contact, via touch. It's not like pneumonia or
Even with body fluids, even with
not
anything,
at all.
it cannot be
There is
transferred.
no
Yes.
way to transfer it from one person to the other. However, a genetic component does exist. If an individual's parents or first-degree relatives do have diabetes, then the chances in the long run of developing diabetes do tend to go up. But to answer your question, no, it's not contagious.
Thank you, sir. Furthermore, sir, if somebody is diabetic, do you think they'll fall ill more frequently than people who are not diabetic?
Okay, yes and no.
Yes and no. Okay.
Diabetes itself is what we call an immunocompromised state.
Yes.
In the sense that your immune system is considerably weakened due to the presence of diabetes. So the chances are you might catch a worse bug, but that doesn't mean that necessarily that you'll always be more commonly sick than your non-diabetic counterparts. However, if you do fall sick, the kind of organisms, the kind of bugs that could affect you might be worse off than your non-diabetic friends might have.
Okay, so the last one, sir, and this one is interesting, and this is something which even I think I got wrong when my father was diagnosed. So diabetics can't eat sugar, but they can eat as much fruit as they want.
Okay. I think you've heard the statement before, too much of anything is wrong.
Yes.
Okay? There are some red lines for people with diabetes. And the way I try to explain this to patients is that any food substance that causes a sudden spike in your blood sugars should be avoided. If you've noticed, when we break our fasts after the holy month of Ramadan, we tend to use a date. The reason is, after a 12 to 16 hour fast, a non-diabetic body requires a sudden boost in his or her glucose levels.
Yes.
A date will provide that. For the same reason, dates should be avoided in patients with diabetes. For those of us who are fond of watching sports on TV or playing them, if you've ever seen a tennis match on telly, what do they eat in the gap in between sets? A banana.
Yes, a banana. Yes.
A sudden spike in blood glucose.
Yes.
For the same reason, patients with diabetes should avoid bananas.
Right.
There are lots of fruits that are generally advisable. Patients can have an apple, a pear, half a guava, for example. Some fruits come in the mid-range that you can take them occasionally, for example, peaches, etc. Some fruits have a very high glycemic index as well, which for a diabetic patient, as we already touched, bananas, mangoes, melons, these need to be avoided to the best degree possible.
Yes, okay. Right.
Because anything that causes a sudden spike isn't something that's going to be healthy. So our focus should be on low glycemic index foods, foods and fruits, as you mentioned, that cause a slower release of glucose into the body. And that helps you regulate your blood sugars better. The actual problem that we encounter is the sudden spikes and the sudden falls. That tends to be worse than either a sustained rise of blood glucose. So that yo-yo effect is something that we need to avoid. Hence, high glycemic index foods, processed foods, soft drinks, sugar-sweetened beverages, the fruits that we've already mentioned over here, bakery items, refined products, and sugar, obviously, are all very high glycemic index and will cause a sudden rise in blood glucose. So they need to be avoided.
And sir, if I am a diabetic and I go to my HCP, he will or she will be able to guide me regarding all these dietary options easily,
I
right?
would definitely hope so.
Yes.
They should be able
And
to.
we should ask them.
We should ask them.
Right.
At the same time, let's be very honest, Saqib, I'm not a nutritionist.
Yes.
So when it comes to my ability to count calories, to make a diet plan for my patients, I may have some limitations. I can give them the do's and the don'ts. I can say what they should take, what they shouldn't take, what they should avoid at all costs. But if they ask me, sir, please give me a diet plan, I don't think I should hesitate in referring them to a nutritionist, to a dietitian, especially if they want to lose weight. You see, you and I both, we probably understand this fact that to lose weight, we're looking for an average 500 calorie restriction
Yes.
in 24 hours. But translating that to a piece of paper, a document with different menus for our patients to use. Now, this is actually a speciality. And I do tend to recommend to my patients who are struggling with their meals that I can give you an overview. I can give you some guidelines, but I would recommend that you meet a dietitian. And I think my fellow HCPs should also start doing this as well. That, okay, you may have a very busy clinical setup going on. You might not have the entire time to explain the dietary regimen in detail. And let's be fair, we might not be fully equipped to understand the patient's food choices, give them something that they're comfortable taking. I mean, I don't think I could advise a patient who's come from a village background to have a cup of boiled oats every morning.
Definitely.
Would not be fair.
He doesn't understand the concept, yes.
That would be unfair.
Yeah.
So I should take the help of a colleague who's a nutritionist or a dietitian to make something a bit more tailor-made. You mentioned earlier there's one size fit all. We were talking about guidelines. The same thing applies to meal preferences.
Right.
The same thing applies to diet. Saqib's diet in the morning might be very different from my diet.
Yes, sure.
It doesn't necessarily mean either of us are wrong. But if we're struggling with weight or with diabetes, that means we do need to change something. And that change should be with the help of a professional.
But sir, again, maybe a different question for you. Is that really happening right now? Are the doctors, telling the patients to go and have a specialized consultation?
I agree with you. A lot of people aren't doing this. A lot of my fellow practitioners aren't encouraging dietitian referrals. But we do need to face facts, and that's what should be happening.
Right.
In the West, you've got diabetes specialist nurses.
Yes.
They're guiding a lot of
Specialized teams, everything is specialized, yes.
So even the nurses, they're trained in diabetes management, in foot care management, in basic nutrition as well. A lot of us, quite frankly, don't have the time. And we need to accept that maybe if we don't, then we shouldn't deny something that's a right of the patient.
Yes.
So you're right, it's not being done the way it should be, but it still should be done.
Right, sir.
And for patients who are listening, there is absolutely no harm in getting the opinion of a certified dietitian who can maybe give you a menu plan. It's not about a diet plan. It's about, if I give a patient a set of menus that they can follow throughout the week.
Yeah.
And they can
that
pick
is
and
something
choose.
practical. Yes.
They can pick and choose.
Yeah.
And at the same time, the portion is very important.
How much to eat,
I think as a nation, you've probably noticed this on weddings and functions, etc. Our plates tend to be overflowing.
Oh, yes.
We have absolutely no concept of portion size.
None.
And more often than not, that leads to wastage as well.
Yes.
Another part of us, we feel guilty about leaving something on the plate. So no, we have to finish it as well. Even if that comes at a health cost.
Yeah.
So portion control, choosing the right dishes, maybe choosing from a preordained menu. Not necessarily a bowl of boiled oats in the morning.
It could be something delicious also.
It could be, absolutely. Our cuisine can be very tasty, very healthy, but we just need to control what we're putting into it,
right,
and how much we're actually consuming.
So in between, sir, you mentioned about eating a date and fasting. So if I take you back there, I'm a diabetic. Not from the religious side, but from your medical perspective. Can I fast? Or is diabetes an end to fasting and, Ramadan?
Especially with Ramzan being around the corner, I think that's another very pertinent question. At the outset, let me state I'm not a mufti.
Yes.
So I'm not sharing any fatwas on any religious obligations. But yearly, there's an organization by the name of DAR, Diabetes and Ramzan, partners with the IDF, the International Diabetes Federation, and they publish updated guidelines on a yearly basis. So a few take-home messages from the IDF DAR guidelines is diabetes is not a red line for fasting. Patients with diabetes can fast. However, the question is, should they fast or not?
Or not. Yes.
For patients with type 1 diabetes, who are purely, obviously, insulin dependent, IDF DA, and they've taken religious reasoning from Al-Azhar University in Cairo. Patients with type 1 diabetes should not fast.
Not at all.
Not at all.
Okay.
Because the body has zero insulin.
Yes.
We're relying completely on exogenous insulin.
Yes.
It will be very difficult for them. So type 1s should not fast. Patients with type 2 diabetes who have well-controlled blood sugars are on oral medication and have good sugar control for the last 3 months can opt to fast. However, there will be a need for adjustment in medication. Since we have a lot of medications for diabetes, just summarizing, some of the medications do not result in low blood sugars, which we can call anti-hyperglycemic agents.
And we can ask about them with our HCPs also.
Absolutely. We need to know a patient's medication.
Yeah.
I mean, I'm coming to that point. If you're just taking medications that prevent your glucose from going up, then yes, fasting it can be absolutely safe. However, even if your blood sugars are well controlled, your HbA1c has been at target, you haven't had any episodes of hypoglycemia in the last 3 months, but you're taking medication that has the potential to make your blood sugar go low, then you might need to revisit your medications prior to Ramadan.
Right.
Because adjustments will be required. At the same time, patients who have diabetes and type 2 diabetes who are on insulin, with good control, they can fast as well, but it's mandatory for their insulin to be adjusted. We usually need a 20% dose reduction, and we'll need to swap the dosing for Seher and Iftar.
Right.
At the same time, patients who have poor glycemic control, the sugars are not well controlled, they've had bouts of low blood sugar hypoglycemia, they're on injectable therapy. What I tell my patients is that you should not fast.
Not fast.
The logic, once again, a take-home message is that religiously harming your body is a prohibited aspect.
Yes.
Religiously.
Yes.
You are not entitled to harm your body. It's a gift from the Lord.
Yes.
A patient with poorly controlled diabetes who opts to fast is harming his or her body. So that's where we need to draw a line.
Right, sir. And if I'm fasting and I feel I'm lethargic, or I have palpitations, or I feel dizzy, in short, if I'm going into hypoglycemia, what do you think? Should I continue with my fast, or should I break it?
I think the answer is absolutely obvious. If you're fasting and you have symptoms of either hypo or hyperglycemia, you should break the fast immediately. This comes back to my previous statement that deliberately harming your body,
You cannot harm yourself. Yes.
goes against any religious edict.
Yes.
So if your fast ends up harming you, break it there and then. And one thing that I do recommend for any diabetic patient who decides to fast during Ramzan, checking your blood sugars does not break your fast.
It does not
common
break.
misconception.
Right.
Check your
So
sugars
glad you
multiple times.
mentioned this, sir.
Check your sugars multiple times during the day.
So I'm pricking my finger and blood is coming out, but the fast is not broken.
That blood volume is not enough to void your
Thank you
fast.
so much, sir.
Once again, whatever we're saying right now isn't my own opinion or your opinion.
Yes.
This is backed up from Jamia Al-Hazar.
It's a consensus,
It's
right?
a consensus.
Yes.
It's a consensus.
Right. So, sir, the last question of our show, and I know that you're one of those people who will not dodge it, even though it is a bit taboo, considering our culture, considering our strong beliefs, considering the general population. So, a lot of people in context with diabetes, they go to spiritual healers, and there are certain rituals that are undertaken, and they think that is enough, or that will maybe somehow cure them of diabetes. Have you ever come across this in your practice? And if yes, how do you tackle such a sensitive and such a topic where people's sentiments are deeply rooted in their beliefs?
Although I try to keep religious aspects separate from when it comes to clinical science, but you've asked a very valid question, and the first part, yes, I have encountered such patients. My opening aspect for anyone who I feel is religiously inclined, I mean, once again, not my place to judge, but if I find somebody who bears a religious inclination, I tell them, look, taking medication is sunnah.
It's sunnah, yes.
First and foremost.
Yes.
If the Holy Prophet decided to cure himself of any ailment, he could have just said, Almighty, cure me.
Oh, yes.
But I think for a lesson for all of us is that he took medications and liked to take treatment.
Yes.
Now, whatever those medications were at that point in time, they weren't pills, obviously.
Definitely.
But the purpose remains the same.
Yeah.
Right? Cure, as a religious understanding, is from the Lord. But you don't get it sitting at home.
Right.
You should, in my opinion, take medication. Not taking medication, once again, is harming your body.
Yes.
Number two, I am not denying the fact that people are strengthened by their faith, but sadly, faith healers or quacks in our environment are catching in on the simplicity
Yes.
of our patients in general, offering them cures that are absolutely ludicrous, that within 2 weeks you'll be off insulin.
Yes.
You can tie the string round your foot and you'll be free of your diabetes. Yes. And a lot of those patients end up suffering in the long run. Mm-hmm. One solution that I tend to use without trying to injure anyone's sensibilities is, okay, if you believe that you will benefit from this, feel free to do it.
Yes.
However, we will continue our medication as well.
Yes.
If you believe that ABC, XYZ is giving you some sort of spiritual water, as long as it's just plain water, feel free to take it as well. However, I will recommend that you continue taking our medication. And at the end of the day, when you're, God willing, when your HbA1c is under control, you can thank your spiritual healer as well. Maybe it's a shared effort. Right? But don't abandon medical management at all. Because what we end up with, sadly, is situations that essentially incurable. Somebody who's lost their eyesight, somebody who's gone into kidney failure. Now, despite my best intentions, I can't reverse any of that.
Yes.
But my opening with this always is that taking medication is also a religious practice. It's sunnah. So going against it isn't advisable either. A lot of patients do understand that, by the way. Mm-hmm. When they're actually told that, look, it's not just what I'm saying. When they're counseled.
Yes.
When they're counseled, that I'm not trying to be too big for my boots. Obviously, the cure is from the Lord. I might just be a vessel for that purpose, and I'd consider myself very lucky if that happens. Mm-hmm. But you explain things on their level of understanding, and I think you can manage to get through. Sadly, quackery will exist. You will have people carrying brooms, brandishing them around people's head, getting spirits to fly out of them. This is going to continue. Mm-hmm. It's something that's here in Pakistan. It's across the border in India as well. You'll find these pockets everywhere in the world. But the only thing that we can try to do is to educate patients, and at the same time try to urge them to understand what the problem is, even to a certain degree for those who have the educational understanding, to understand how their medication works, and to understand that diabetes is multifactorial.
Yes.
There are lots of things that we need to do. Medication is just one of them. And it's a journey. Give them a say in their management. Mm-hmm. What I tell them, okay, look, this is something that we're going to do together as a team. I'm not going to force anything down you. We're going to look at the problem. We're going to identify our targets, whether it's diet, whether it's exercise, whether it's weight loss, whether it's medication. We're going to try to come to a consensus.
Right.
And we'll hope for the best to follow.
Inshallah. So, sir, to sum up our program, what does Dr. Ali Arif in relation to Pakistan and diabetes see in the coming 10 years? Is it a positive outlook? Do you think patients will be more better managed in Pakistan, or will it be the opposite of it?
It's a bit of a grey area. Mm-hmm. As hopeful as I may be from our friends at the pharmaceutical industry, with newer drugs coming through, with a lot of medication that has benefits beyond sugar control, we now have a lot of these available as well. The problems in society are very deep-rooted, and the prevalence of diabetes will continue to rise. I don't see any shortcuts there.
Right.
We should be undertaking lifestyle reform on a government level, on a societal level, trying to improve quality of life. But we are a resource-strapped developing country. We have a lot of myths embedded in society. So sadly, I don't really see us managing to prevent diabetes the way we should. Sadly, I still think we are going to... We're already up to number 3.
Yes.
We might be on number 1 before we know it.
Yes.
I don't see us falling down back to number 5 or number 6. But I do see that with the advent of newer medication, we might be able to achieve quicker glycemic control. We might be able to prevent diabetes-related complications like heart disease and kidney disease. But as far as the prevalence is concerned, I think it's going to go up.
It's going to go high. Right.
Unless, of course, we decide as individuals, as patients who have family members with diabetes, individuals who themselves don't have diabetes but are caregivers for patients with diabetes, to step up and make a change.
Right, sir.
Change has to come from within. You can't force it on anybody.
It has to.
If we do that, then maybe the road ahead might not be so bumpy. But if I were to see things now, where we're currently headed, we have quite a tough time to follow.
So we are very thankful to our guest speaker, Dr. Muhammad Ali Arif. And sir, thank you for letting us grab you out of your busy schedule. I would also like to thank our audience who have tuned us to our show Meethi Baatein, and would like you to please tune in again in the next episode, where we will have a guest speaker and we will discuss this topic, Pakistan and diabetes, in much more depth. Thank you so much.